This video is a duplication of a presentation given by me in San Antonio, Texas in December 2015 at the AMSUS annual conference and convention. The title of this presentation is Specialty Support Groups for Combat Medical Personnel, What Works and What Doesn't. I'm Guy Lamunyon. I'm a retired Army Psych mental health nurse and a retired VA mental health nurse. At present, I'm an adjunct instructor at Northern Arizona University, teaching clinical psych and research. Also, I'm a recipient of the Order of Military Medical Merit upon my retirement in 2010. This is a disclosure statement required. This presentation was previously given at the 22nd Annual International Military and Civilian Combat Stress Conference in San Diego, California in May of 2015. My qualifications to do this presentation include service as a combat medic, 101st Airborne Division, Vietnam. Upper left photo is me on a patrol routine in the jungle. Lower right is a combined mission with the 5th MEC in the rock pile area of operations near Quezon, and the middle is me preparing for Battalion Reaction Force, currently known as Quick Reaction Force. The upper left is a photo of me suturing a soldier in the jungle. Lower right is my retirement photo taken at my home in Sedona, Arizona. The middle are some awards that I received while serving enlisted with the 101st Airborne Division. I wanted to tell you about an amusing thing that happened during my last AMSUS conference in San Antonio. That time I was an Army captain, and I was seeking the registration desk and looking not at people's uniforms but on their AMSUS badge to see who had actually checked in or not. And I spotted a soldier wearing a uniform that had already checked in, and I said something profound like, "Yo dude," or "Hey man, where's registration?" I looked up. Sure enough, 3 stars. It was Lieutenant General Peak, then the Army Surgeon General. Later he saw me in uniform, figured out that I too had served like he had in the 101st Airborne, and he gave me a smile, and all was forgiven. This presentation is about the complications of combat service for Army medics and Navy field corpsmen, which they know well. Different from treating trauma patients in a hospital that you're not familiar with, these men treat people they live with every day and sometimes are closer with than family members. And there are a few learning objectives that are required. This presentation is about a support group for combat medics and corpsmen that I started while I was working at VA Long Beach in 2007, and at the present time is the longest running such group that I've been able to find. And I'd like for an actual participant to give you the introduction.
Go. Hi, I'm Doc Dave Pfeiffer, 101st Airborne, Vietnam, 1969 and 70. LZ Sally, just outside of Wade. I was in the 2nd platoon out in the jungle for a year. I I was diagnosed with PTSD and doing the group therapy down at Long Beach VA. And I was talking to lots of other guys with different MOSs, mostly 11 Bravo. And it occurred to me that I wasn't really talking with other medics. And I thought medics needed to talk among each other because we had kind of certain needs to talk among each other different from the GIs. I ran into a fella and became instant friends, Guy Lamunyon, who was another medic in the airborne, 101st of course. And we hit it off famously right away, had so many things in common, and discovered that we were in the same outfit back to back, 1 year after another, which made us instantly close friends. And we got talking, and after having so many things in common, we agreed that medics needed to talk together and share experiences because we'd had so many of the same, well, incidents, if you will, that when we worked on patients in the jungle, our fellow brothers, if you will, we would hear, do, and experience things like no other veterans ever experienced. And with these shared experiences, it made us unique and separate. We weren't able to really talk and share these experiences. The other veterans didn't want to hear those last words that we heard that stuck with us for the rest of our lives. And we might even remember them in our sleep, in our nightmares, in our memories that never went away for the rest of our lives. Who are we going to talk to about those kinds of things? And when we do therapy with the other GIs, yeah, it's nice to talk about surface events, battles, places we were, things that happened, but we're just scraping the surface. We're not really going deep and hearing the things that really get into our heart and our soul that bother us at our deepest level. And medics need to share those things, air those griefs out to get down there, the things that really move us the most at our heart and our soul. And fellows came to us and asked us questions about religion, about their wives and girlfriends back home. We were the ones they turned to with the Dear John letters. There were so many things because we were the medic that they came to depend on us for so many things that it's even hard to describe in words that we carried home with us. When we treated them in the field and sent them off on a medical helicopter, medevac if you will, we never got to hear what was the result. If that patient survived because of the efforts we did, the things we did in the field, we didn't get a final resolution to know if these guys came back alive, if they went back home to the States, if they went to the hospital in Japan. We don't know what happened to them. It's unresolved. We need to talk among ourselves and air some of these things out. And PTSD is good, and the group therapy is good, and all that, but it's not really a finishing product for us because it goes so unresolved in so many areas. For the medics and the training we had, it's an unfinished product. It goes unresolved, and we walk around with all these things that are still going on inside our minds and our hearts. I think medics need to talk among other medics. Maybe it needs to be part of the training program, I don't know. But there needs to be more discussion. There needs to be more therapy. I think we need a medics program that's devoted just to medics.
So I had left VA Long Beach in 2009, transferred to VA in Prescott, Arizona, and had not thought a lot about the medics group and its direction or whether it was still in existence. I began to read some new models, new thinking and new research about combat medics. First was Dave Grossman's work And as far as I'm concerned, this is required reading for anyone working with combat veterans. His books on killing and on combat, about the psychology of killing and in combat. Charles Figley's work. Figley was a combat medic in the military, and he's done some writing on help for the combat medic, and he's well known for his work in PTSD. And Bill Nash, Captain Nash, has popularized the concept of moral injury, and we're going to get into that a little more later in this presentation. And Paula Chapman, also Army medic, said she graduated top of her class, had done some pretty detailed research with combat medics, telling us what we knew in 2007 and a lot of time before that medics had unique and special problems, and they should be addressed. So we had a discussion and decided to do a pilot group. The PTSD program psychologist, Dr. Houston, agreed, and we developed some admission criteria that anyone coming to the specialty medics group should have completed the basic PTSD program, mostly psychoeducational at that time, that they should be referred by clinical staff, and it was restricted to combat medics and corpsmen. With no discrimination about war or conflict. We'd take anybody that had been in combat. We made a flyer to post and distribute in staff meetings, and to be shown to potential medics and corpsmen that might come to the group, and included a nice quote from David Hackworth. David Hackworth is the Audie Murphy of the Vietnam War. His awards are 2 Distinguished Service Crosses, 10 Silver Stars, 4 Legion of Merit Awards, 8 Bronze Stars, 8 Purple Hearts, and 34 Air Medals. The methods we used, I'd contacted a nearby VA, the VA West Los Angeles, the largest in the system, to find out about their combat medic group, but that had been disbanded and nobody had much information. So we had 0 information to start with, and I decided to do an initial stakeholder meeting. More about that later. And we, of course, used a group discussion format, which is good evidence. That's helpful for people with PTSD. I used some videotapes of combat medics in operation and combat medic training. This is my low-tech virtual reality. This is a method that I learned from the vet centers when they opened early. They showed combat footage to bring people back to the event and make it easier for them to open up and talk. I used some military training materials, and had weekly supervision with the psychologist. So in the stakeholder meeting, we asked and wrote on the board, why are you coming here? What are you interested in? What are the special and unique problems that you think combat medics and Navy corpsmen need help with? And this was the list. They said they wanted to feel that they were being accepted by their peers. They wanted to talk about the unique issues of combat medical personnel. They wanted to receive feedback from their peers, which is the other medics and corpsmen, and seek peace of mind. They also wanted help with symptom management, dealing with memories, problems with emotional numbing and shutting down, and self-esteem. They also wanted help with family problems. Many identified anger as a problem, and some wanted help with welcome home, feeling after the Vietnam War we didn't get much of a positive reception. And some were saying they had problems with guilt, and they wanted help with their guilt problems. Others said they had adjustment issues and problems with what they said strength under pressure, which is coping with stress or stress problems. And some said that they were having medication issues that they were hoping to get help with. So we generated a second flyer to put up with the items that I read and many other issues, including the spiritual issues Doc Dave talked about in the introduction, survivor guilt, telling people that they knew were dying, that they're going to be okay, help being at home, crying, and compassion fatigue. So I decided I could put together some case studies for our presentation. And the first case study is Doc Dave that gave the introduction, and he already tells you he's a combat medic with 101st. After the military, continued working in medical, got a degree in mental health, and worked in mental health. He did not know he had PTSD until at one time he was uninsured and went to the VA for medical help, I believe in a case of pneumonia, and they found out he had severe PTSD. And Dave is also the author of an autobiography about his combat experiences. The second was a medic, not a combat medic, that asked to be admitted to the group. And his story was that he had secondary trauma. He worked in the amputee ward, and he said every night those guys cried themselves to sleep at night. And he said, I still hear them crying at night when I go to sleep. So, of course, we believe in secondary traumatization, and we admitted him. So much for our initial criteria that we would only take combat veterans. The next case I'd like to discuss is an interesting one. A combat medic in World War II who had used his GI Bill to go to medical school and ran a successful practice as a physician. And had no PTSD symptoms, and when he retired, his symptoms emerged. The other thing that had happened was the internet. He began to be contacted by some of the people that he'd served with, and this caused a re-traumatization for him. A Korean War vet came to the group. He was not referred from mental health. A couple of other medics had met him at the VA and dragged him into the group. He was distrustful of the VA and the government, angry and suspicious, and he didn't want to go to basic PTSD treatment. Our idea was to have him in the group for a while and encourage him to go take the basic PTSD treatment. But he did not remain in the group too long, unfortunately. He likely had a pretty severe depression that was going untreated. Gulf War vets fit in very good. They were very clinically similar to Vietnam veterans. They had less combat exposure as a group, all had good verbal skills and were easily able to identify with the Vietnam veterans, the primary members of the group. OIF veterans didn't tend to stay very long. I think we're getting a better handle on that now. At the time that I was there, 2007 to 2009, they didn't want to identify too much with the older veterans. And I suspect to transference, we probably look like Dad to them and spoke like Dad. A little improvement now you're going to see later in some of the video. And then I don't want to forget nurses. One nurse that I met at the Combat Stress Conference, who'd worked in emergency room and been witness to a lot of horrible wounds and injuries. When she retired, the symptoms came back, and she had a lot of olfactory memory. She said, "I can smell the smells." What it was like when she was triggered and had flashbacks. So I decided after figuring out that I could do some case studies to send a research package to the group. So I sent the PCL-5 to measure PTSD symptoms, the post-traumatic growth inventory scale, the moral injury scale, and I developed a survey on the basis of the goals that I talked about in the beginning using a Likert scale. For PTSD, and I plotted these over time, the left-hand side of the screen is year 1, and some had been participants in this group for up to 7 years. So you can see the PTSD symptoms start to drop about year 6. This is a small sample. And this is post-traumatic growth inventory, and no real pattern here. This is pretty random. The moral injury scale, all were elevated, and this confirmed for me a lot of the clinical experiences that I'd had in the group, that many had moral injury. And I did contact Captain Nash about the cutoff score, and the moral injury is not a test-retest method. We would not expect this to change over time and with treatment. So it measures the injury after the military service. Very positive thing that came back was positive results on the things that were bringing the medics and corpsmen to the group. So the highest one, and the scale here was 2, most positive, -2, most negative. They said that they felt that their unique issues had been addressed or were being addressed, and that they felt accepted by their peers and enjoyed receiving feedback from their peers. They felt that guilt, a primary symptom, was pretty improved, 50% improved. Lesser response, but still strong, is adjustment issues. Strength under pressure, that's coping with stress. Improvement in anger, feeling more welcomed. And of lesser importance, help with their emotional shutting down, overall peace of mind and symptom management, and some improvement in self-esteem. Not a lot of improvement with family issues, because family did not, of course, come to the group. Some assistance with dealing with memories, and the least strength was medication issues. So turns out a group full of medical personnel apparently could not agree. So as an update to this initial 2007 group, it's transitioned to a peer support group, still meeting weekly using an open mic concept. and averaging 8 to 12 participants. In the beginning, we put combat docs as a title. As a final recommendation, I think combat medical personnel group or combat medical personnel support group would be a better and more all-inclusive title. So here are a couple of more interviews so that you can hear.
Go ahead. I came to the medics group about in '08, so that's about 7 years ago. And the reason being is that when I was a Vietnam veteran, most of us, when we got out of the military, we just were given a pass and we left, and that was it. And I wanted nothing to do with the military. I was wounded and I had hearing loss already, and so about in 7 years, 8, 10 years ago, my world started unraveling, and all the symptoms of PTSD, the fear, the trauma, the anxiety, it all started coming back. And at that point, well, okay, I know where this is coming from, so that's when I first approached the VA. But when I got to the VA, and the interviewer, and as I went through the process, then they said, okay, you're a combat medic, Purple Heart. They sent me directly over to this group, and I have been here ever since. I can tell you that the benefits have been, I mean, you can't, clinically, put them down on paper, but the group, the format of the group where we're all together, we're all on equal footing. We know each other. We understand what we've all gone through. And that in itself is what kind of nurtures an openness and a desire to come out and, discuss your issues. I've been here with a group where we had veterans from World War II, the Korean War, on down to the current Iraq, Afghanistan issues, and we're all brothers of the same issues and traumas that we've all experienced. Granted, okay, we're all on medication, we're all on doing different things for ourselves, but the camaraderie and the brotherhood that this group has created, it's an intangible. It's you can view it as a medication, so to speak. You come here for your dose every week, and I'm saying things that the younger vets are also saying. This is why we come here.
And how could it be improved? How can we do this better?
That's a good question, and I'm not a clinician. I can say to you that having at this moment we don't have any professionals to kind of guide with us, but having a professional might be a way to improve, so that somebody who is clinically trained can enhance the dialogues and give us perspectives and allow tools and techniques that we can work with to continue. I am aware at my 60 years of age that this is a lifelong struggle. I have learned to deal with it and for a quality of life. And if anything, at this stage of my life, it's not just so much for me anymore, but the younger brothers that are coming behind me. They're the ones that need to be attended to, and this is a program that has helped me, and obviously I'm sure it will help many others.
My name is Peter F. Martinez. I was a combat medic in Vietnam, 1968 through 1970. I did 2 tours, one with the 196th Light Infantry Brigade. The second tour was with the 91st Evac Hospital. I waited 40 years before I asked for assistance from the VA, and mine is a little selfishness. I asked for help from the VA so that my wife would not have to go through the trials and tribulations of being married to a combat person and not understanding why I did the things that I did. So mine is so that my wife did not have to go through these. When I came here, I was diagnosed with PTSD. Also been Agent Orange, which gives you a lot of other affiliations to diseases, diabetes, and other things that you get being in Vietnam. Coming to the combat medics group, I was referred to by my psychiatrist. I came here, I listened for a year without saying anything, and then I progressively started to engage myself with the class. Recently, I have become a leader in the class where I am a facilitator for the peer-to-peer, and so I lead the group. How do I feel that the group should be able to progress? I feel through education is the best way for them to progress. Education in taking more classes here at the VA to enhance their ability to deal with PTSD and other symptoms that they may or may not have. And that's pretty much about it.
Oh, what? Well, I served with the 101st Airborne with 3327 Infantry Regiment as a medic with Delta Company. When I first got out of the service, I didn't know what was going on. My brother-in-law asked me, "Hey, what's up? Why are you always locking yourself up and stuff?" And then I didn't really thought nothing about it. And then about 5 years ago, I was having problems and stuff. I was already married. My wife was getting mad at me, and I didn't know why I was getting angry. So, and then I know it's just my dream just gotten worse and stuff. So I went to end up getting to outpatient psychiatrist and get checked out, and then I found out I had PTSD, and then so they referred me to this outpatient psychiatrist and had an appointment. And then I went through the group and stuff with a CPT graduate group. And then while I was doing the process, there were one of my psychologists told me, there's a combat medic group. Do you want to go to that? Because since you don't know anybody, because everybody in my group I went to were all Vietnam veterans, I was kind of young with that group. So I went to that group, referred to it, with Dr. Houston was running the group. And I was very surprised that all these guys had the same thing I did, but the time periods were all different. I met one guy who was also from my time period, Desert Shield, Desert Storm. Same time I met guys for OIF, World War II, Korea, and in Vietnam era. And then at that point, I felt alone anymore, because I knew that they had the same feeling when I first started in the group. Also, I was very quiet because I was trying to assess, because at that time I still didn't feel comfortable. I never felt comfortable anyway with a group of people. As I got to know the guys better, I started talking more, and then I thought coming to the group was very helpful. At least once a week, it felt great just coming there. Talking with these guys were also medics and corpsmen and stuff. And then when I felt something not right, I talked to them about it, and I get response from them. And then it kind of at least made me feel great that day, and I was looking forward to come back every week for it. But I think the group, in my opinion, is very helpful because I felt comfortable. At least these guys were in the same situation I was, but the time periods was a lot different. So I still come here once a week, just feeling relief, talking to these guys.
How could we do it better? How could we improve?
How can we improve? I guess kind of get us more understanding what's going on with us, because I'm actually a nurse, and I still don't quite understand what's going on with me. At least I wish they could explain it a little bit more, other than the guys just telling me, we have that too, and this is what I do with it. But I wish I can understand a little bit more, because I still quite don't understand it myself.
Okay, great. Okay.
My name's John, combat medic. I served in the 25th Infantry Division out of Schofield Barracks, Hawaii. I was with 121 1st and 21st Infantry Battalion. Served in Iraq 2007, 2009, and then Iraq 2010, 2011. I was, after I left Hawaii, I went to Fort Jackson to a TRADOC post where they trained soldiers, and I was really, really angry, and I started seeing therapists and trying to figure out what was wrong. And I think what hurt me the most is I was going to stay in the Army for 20 years and retire. When I was diagnosed with PTSD, they started telling me that I couldn't stay in anymore. And when I retired last year, I was really messed up, and I came to the VA and I think I asked the combat medic group. I'm pretty sure I did, just because everybody I met said I was screwed up. my wife, my mom, everybody. And I didn't see it, but when I started coming to this group, the Vietnam vets saw it. And it kind of scared me that the Vietnam vets thought I was that messed up, that angry. But coming to this group, this is my first time in a medic group. It's helped more than I could even imagine.
Okay. How can we do it better?
Just keep it up, spread the word. I'm actually moving to Texas soon, so I need one in San Antonio. So let's do it.
So as an update, this is now a peer support group using an open mind concept. And I think a better title than the initial combat docs would be Combat Medical Personnel Group or Combat Medical Personnel Support Group. At present, it's peer facilitated. The VA puts a value on peer support and peer helpers, and that seems to be a good solution as of this point in time. Here are the lessons learned. Completion of a basic PTSD treatment is desirable but not required. I gave some clinical examples of that. Not too effective for the reduction of PTSD. If you remember the curve, post-traumatic growth, we didn't have much of a response. And for moral injury, we wouldn't expect any change on the measure that we had, but we would expect changes in self-reports. It is effective to assist with the unique problem combat medical groups personnel have, and a separate group may be necessary for OEF. Future planning is to develop a combat medical personnel website. I'm working on that to catalog research and treatment information, to submit for a 2015 AMSUS presentation, which is completed, to submit for a Department of Defense virtual workshop, which I'm on the waiting list, to prepare a publication, and to submit for a VA best practice. I like this graphic representation of a model for moral injury, seeing the symptoms of moral injury and PTSD and the symptoms that overlap. The overlapping symptoms are anger, depression, anxiety, insomnia, nightmares, and self-medication. The symptoms unique to PTSD is the startle reflex, memory loss, fear, and flashbacks. And the unique symptoms of moral injury are sorrow, grief, regret, shame, and feelings of alienation. The literature regarding moral injury says that it's related to killing. That's for infantry and combat personnel. So why would corpsmen and medics have moral injury? Our moral injury is the inability to save our comrades, who we may have had coffee with in the morning and be treating for enucleation, loss of limbs, loss of life, and other horrible injuries in the afternoon. People that we grow very close with. So, suggested model for future use going forward with combat medical groups is the emerging moral injury model by Litz, Nash, et al. And this is the overview. To make connection, preparation and education, a modified exposure content, examination, integration, dialogue with a benevolent moral authority, reparation and forgiveness, fostering reconnection, and then lifestyle planning. So as with any therapy, the first step is connection, building trust, and many may have never told any person the things that they're about to tell you. So they need to develop trust for as a first step. And then education is recommended about, this whole continuum of treatment and PTSD treatment and what expectations that they can have. The exposure content suggests a projective exercise, having the client close their eyes and relive, redescribe the events that are still bothering them. And then, cognitive examination of this, focus on self-forgiveness. Another important, and probably the most important point of this treatment is with a benevolent moral authority. The model recommends a projective exercise. However, in the military and in the VA system, we have good access to chaplaincy, which is understanding. So I would rather suggest a chaplaincy referral or having a chaplain come to group from time to time to help them deal with areas of forgiveness. So self-forgiveness is another important part of this treatment and the desired outcome. And also it's suggesting that they continue on and do amend making where possible. And in this book, Combat Medic Vietnam, the one of the medics that tells this story here says that he went to the home, the parents of every person that he treated for a critical wound and explained in great detail, how their loved one was lost. So it sounds like a great way to resolve this problem. And fostering reconnection, psychosocial improvement is another goal, and then preparing them, at like the end of termination of any therapy, planning for them to live a successful life. So in review, this is an 8-step process that's recommended. And I have some closing remarks by Dr. Dave for you.
I thought we did well, and we covered lots of ground and lots of different and varying experiences. And of course, there were some Navy corpsmen that were in there that were trained slightly different from us. And it was interesting to see the kind of equipment and the way they were trained and how they approached dealing with their patients as well. I thought we got, each and every one of us, a lot out of the experience, and I would hope that that kind of a therapy group would expand and go throughout the VA system. I, for one, would vote for that and hope that people in authority would see that needs to be done. The medics need to have a place to go and experience that and a greater participation. I thought I gained a lot of insight, and I thought the other medics did too, learning about their brothers and their combat experience. There were a lot of pluses and minuses to take from the group, learning and experiencing from each other. Lots of good came out of it, and of course being able to catharsis and ventilate a lot of the backed up emotions and feelings and experiences that we had was a very positive thing. Meeting our other medics from all over and the differences and of course finding out what happened to them when they came home and finding out the vocations and what they went into and how their lives changed as a result of it was very moving. And how they decided to cope with their experiences was very enlightening. I think that we all needed to learn from that and take something from it. The minuses were some of the veterans that, or medics that took negative experiences from it, that were non-combat vets that didn't adjust well, didn't adjust to being in group therapy with combat vets. Apparently some of them didn't mix well with the combat vets and didn't like hearing our stories, and that part of it didn't go well. I would suggest that there should be a separation of combat medics from the non-combat medics, that in the future that separation would work well in the future ahead. But all medics need some kind of a group to differentiate themselves from the common veterans, or the 11 Bravos, if you will. Anyway, that's all I can think of for the moment.
Thanks, Doc. So here's my contact information, my personal email, the combat stress conference website. I'm starting to catalog some information there, and my work email is probably the least reliable. So in the future, I'm going to start a book, Combat Medic 101, everything I needed to know I learned at Fort Sam, which is the training site for Army combat medics. And thank you for watching the video. If you have questions, you can please contact me. Thanks.